Welcome to today's session of the EAJNS Journal Club Critical Appraisal Bootcamp. My name is Ligitao, and I'll be serving as your moderator for this session, and I'm representing the XYZZ Med. So, as an introduction, the EAJNS Journal Club is a collaborative initiative by the East African Journal of Neurological Sciences, together with partnering journals, including the Journal of the Kenya Association of Physicians, that is JOCAP, the Journal of Obstetrics and Gynecology of Eastern and Central Africa, the Annals of African Surgery, and the Anatomy Journal of Africa. So this initiative is implemented in partnership with XYZZ Med, SCORI Research Exchange, the University of Nairobi Research Club, CUMREC, and the Student Surgical Forum, with support from EIFL, Knowledge Without Borders, and Daktari Online. Through this bootcamp, our goal is to strengthen critical appraisal skills, deepen engagement with African scholarly journals, and inspire medical students and early career researchers to actively participate in research, scientific publishing, and peer review. Today's session will focus on the critical appraisal of a systematic review using the AAS, that is the Annals of African Surgery Critical Appraisal Framework. Systematic reviews are one of the highest levels of evidence in the research hierarchy, as they synthesize findings from multiple studies to provide comprehensive insights into a particular research question. However, the reliability of a systematic review depends heavily on the rigor that is used in its methodology, including the clarity of the research question, the comprehensiveness of the search strategy, the study selection criteria, risk of bias assessments, and the methods used for data synthesis. Learning how to critically appraise systematic reviews therefore allows us to determine whether the conclusions are trustworthy, clinically relevant, and applicable to our setting. So our session will run for approximately 1 hour, and the structure will be as follows. First of all, we'll have a 15 to 20-minute presentation that is led by Stacey Akinyi, who will introduce and summarize the systematic review and a discussion. The presentation will cover the research question, the search strategy, the inclusion and exclusion criteria, the methodology, the key findings, and the conclusion of the review. After this, we'll have the normal 30-minute interactive discussion where we will collectively appraise the paper. During this segment, we will focus on important aspects such as the clarity of the research question, the comprehensiveness of the literature search, the study selection process, the risk of bias assessment, the data synthesis methods, the strengths and limitations, and the applicability of the findings to clinical practice in our context. Finally, we will conclude the session with expert insights from Dr. Mercy Mitei, who joins us as a part of the editorial apprenticeship program at the Annals of African Surgery, and who will share reflections from an editorial perspective on evaluating systematic reviews. So we encourage everyone who is a part of the session to actively participate throughout. Feel free to share questions, to share comments or critiques during the discussion segment. The Journal Club is designed to be a supportive learning environment where all of your perspectives are welcome, regardless of your level of experience in research. So with that, it's my pleasure to invite Stacey Akinyi to take us through today's paper as we begin our critical appraisal of a systematic review. So Stacey, you can begin.
Thank you so much, Lee Gitao, and hi everyone. I hope you're all well. So as he's introduced me, my name is Stacey. I'm the outgoing Nori for SCORI. That's National Officer for Research Exchange, and this is what we'll be doing today. So the title of this study is Prevalence of Traumatic Brain Injury Among Trauma Patients in Ethiopia. It's a systematic review and meta-analysis. And here I listed the names of the authors of this paper. So they're from there's Seman Mekonnen Abate, Bedru Jamal Abafita, and Tesfanu Bekele, and these are the universities that they're affiliated with. So let me just move my slide. Okay. Yeah. So the aim of this study was to estimate the national prevalence of traumatic brain injury among trauma patients in Ethiopia. And okay, yeah. And so now we can go to the introduction and the background. So before I share with you guys the conclusion from the whole background and introduction that's in the actual paper, head injury is a common cause of mortality and disability in young age population, particularly in children and adolescents. And traumatic brain injury can negatively affect families, communities, economies of countries. And it's estimated that in the USA, for example, 5.3 million people are living with traumatic brain injury related disabilities, and 7.7 million people in the European Union have also experienced TBI, who have experienced TBI rather, have disabilities. So now to give you guys kind of a summary from what I got from this introduction. Of course, again, TBI is one of the leading causes of death and disability worldwide, especially among young people. And globally, over 10 million people sustain TBIs every year, leading to death or severe disability. And in low and middle income countries, TBI incidence is rising due to increasing motorization, poor road safety measures, and inadequate trauma care systems. Okay, so the research question was, what is the prevalence of TBI among trauma patients in Ethiopia? And for the study design, the authors used a systematic review and meta-analysis of cross-sectional studies, and they followed PRISMA guidelines, and they registered on Prospero, and this is the Prospero registration number. The search strategy that they used, the authors searched PubMed, Science Direct, African Journals Online, and Google Scholar, and they used 3 stages. So first they had an initial search, and then a keyword and indexed term search, and then screening of the reference lists. So for the studies that they included cross-sectional studies reporting TBI prevalence among trauma patients, and studies conducted in Ethiopia. And they excluded RCTs, cohort studies, case reports, reviews, and any studies that were not reporting on traumatic brain injuries were also excluded. So for selection, initially they selected 198 articles, which they found after screening. Then they reduced them to 21 articles. And then finally, they were able to include only 12 studies following the inclusion criteria that I listed in the previous slide. So the total participants of these 12 studies were 14,017 trauma patients, and 5 regions were represented, specifically Oromia, Addis Ababa, SNNPR, Amhara, and Tigray. And also, it's important to note that some Ethiopian regions had no data, and I think we'll be able to see that in a few, like in the next slides. So for data extraction, they did it through 2 independent authors who extracted the author of the paper, the year, published, the sample size, prevalence, participant age, and risk factors. Then any disagreements were reviewed by a third reviewer. So they analyzed the data through the R software version 3.6.1. They used random effects model because the studies were heterogeneous. So they assessed heterogeneity, and publication bias was also assessed using funnel plot and Egger test. So in this slide, I wasn't able to show you guys a picture of the funnel plot and Egger test, but we will be able to see some graphical representations of some of the results that were found as a result of this data analysis. Yeah, so, and I think this is one of them. Yeah, I think it's a bit more clear now. So just like it's been written in the description, this is figure 2. It's a forest plot for an overall prevalence of traumatic brain injury. So I'm not sure if you guys are gonna be able to kind of see my cursor. I think you actually are not going to be able to see it. But what I'm going to do is I'll just explain what you are kind of seeing here. So here, each square that you see, even if you're not able to see my cursor, represents a study, and then the horizontal line, if you can see the horizontal line, it represents the confidence interval, and then the diamond, which you can see down here, I'm hoping you can see the diamond down here. So it represents the pooled estimate. And so this figure is like so important because it's trying to visually show us how the pooled prevalence was calculated. And so I just got this forest plot image from the paper itself. And so in summary, the conclusion that this forest plot is showing us is the authors calculated a prevalence of TBI, which was found to be 20%, and the confidence interval with a 95% confidence interval of 11% to 32%. And so approximately 1 in every 5 trauma patients has traumatic brain injury. So I don't know if I need to go back to the slide so that you guys are able to see it and synthesize it a bit better. Yeah, but I hope you understood this particular forest plot. Okay, so now we'll move to another plot now for mechanism of injury. So now this is a forest plot for subgroup analysis of the prevalence of TBI with mechanism of injury. And so you might not see well, but like right below where it's written study, this word that's here that's looking a bit gray is assault. And then the other batch of words, like there's a gray subtitle written RTA. Sawa. So the first batch is for assault and the second batch is for RTA. I believe the numbers are a bit more visible than the words are. Yeah, so now let's try to synthesize this image again. Remember what we said about what each square represents and also the diamond. The diamond is the thing you can see now in blue. So this one has 3 diamonds, the other one had 1. Okay, so let's see the results. So this subgroup analysis, it's demonstrating that road traffic accidents, which you can see down like this second batch of things that are listed down here, were the leading mechanism of traumatic brain injury, followed by assault. So I hope you guys are kind of able to see. So let me go to this next one here. So you can see like the road traffic accident. If you guys look at the plotting, it's at 21% prevalence. And then assault, this one yenye iko hapa juu, is at 18% prevalence. So let me just go back. Yeah, so this just basically shows that road traffic accidents are the leading cause of traumatic brain injury in Ethiopia, in summary. Okay. Higher. And then the last one that I put, so I know the paper has many diagrams, but I just wanted to explain these 3. And so for this one, it's figure 3, it's forest plot for subgroup analysis of the prevalence of traumatic brain injury of the region. So this forest plot is trying to demonstrate a subgroup analysis by each region. Like I said in the introductory slide, we were looking at Tigray, Oromia, and Amhara. So this is basically what conclusion was made from this. It shows that there's a lot of variation, I would say, in the traumatic brain injury prevalence across the Ethiopian regions. And so Tigray, for example, has the highest prevalence, which is at 49%. And then Oromia has around 20%. And Amhara has the lowest at 15%. So again, the gray words that maybe you're not able to see well are the region. So you can see Addis Ababa, Amhara, Oromia, SNPPR, and Tigray. Yeah, and so I hope I have explained that well for you guys to understand. Yeah, so again, this is just explaining the previous slide. The prevalence by Ethiopian region, Tigray is highest at 49%, Oromia at 20%, and Amhara lowest at 15%. And so the overall results, now like in summary, first, 1 in 5 trauma patients in Ethiopia have TBI, which we saw from the first figure. And then secondly, 2 main mechanisms of injury were noted as the causes. That's RTAs at 21% prevalence and assault at 18% prevalence, which we saw in the second forest plot. Then there were regional differences with the highest prevalence of 49% in Tigray and lowest prevalence of 15% in Amhara, which again we saw in the third forest plot. And then no significant publication bias was detected through funnel plot and eagle test. Again, this was expressed, or rather was shown in the full text, but then I've not included them here. But yes, that's kind of the conclusion. So they didn't find any publication bias. And then limitations. So the authors reported the following limitations, and I've listed them here. So first, there are a few studies that were included. Some regions had no studies, just like we've been saying for the past few minutes. There's high heterogeneity between studies, and then they also reported evidence is based on cross-sectional studies. So there's very low evidence level. So the conclusion that the authors came up with was that traumatic brain injury prevalence among trauma patients in Ethiopia is high compared with global reports. Road traffic accidents and assault are the major causes. So the recommendations that they had were first, having stronger road safety laws, then having also better transport regulation, and developing pre-hospital emergency care systems. So these are the references. Of course, the first reference was the paper itself, because that's where we got most of the information from. And I'm done presenting the summary of this paper. So maybe I'll hand it back to Lee. Thank you.
Thank you, Stacy. That was a very good, very concise presentation. So now we want to move to the open session of our session. Okay, I believe that the paper is visible. Good. So yes, we can begin. Feel free to comment through the chat box. I'm monitoring the chat box. If you need to unmute, I will give you permission to speak, and we can start on the title. Let's comment on the title, guys.
Yeah, hi. My name is Clarence. I'm a fifth-year medical student at the University of Nairobi. And I would say the title is pretty well written. It's able to identify the type of study, so systematic review and meta-analysis, the population, so trauma patients in Ethiopia, and the exposure, which would be, I guess, a traumatic brain injury. That would be the outcome. Yeah, so I would say it's a pretty good title.
Hello. Yes, Clarence. Thank you. Yes, I agree. The title is very good. It addresses the pertinent points of the paper. If we proceed, let's proceed to the abstract. What can we say about the abstract? Yes.
Oh, sorry.
Yes, Clarence.
I forgot to talk about the authorship. Yeah, so the authors, they were able to identify the affiliations, but their contributions are not listed. And it seems like there are some that were involved in the data extraction process later on that maybe should have made it onto the authorship section. So yeah. Those are my comments on that.
Yes, thank you, Clarence, for your contribution. Sorry, I keep forgetting to unmute myself while I speak. Apologies. Let us continue. Yes, the author affiliations are listed. I can see author 1 is from the Department of Anesthesiology, author 2, Department of Surgery. Yes. Thank you. So let's proceed to the abstract. What do we think? Personally, I noticed that they have noted that the review was registered in Prospero International Prospective Register of Systematic Reviews, and the number is given there, which was one of the areas we were checking in appraisal. I'd like to hand over the floor to you guys to contribute on this.
So my name is Teddy. I'm a pre-intern. So for abstract, it's well structured. It's following the Prisma guidelines, and in the background, They mentioned their objective as to find out the TBI. They mentioned that they noticed that TBI has high morbidity and mortality, especially in the young population. In the methodology, they mentioned the databases they searched, which were PubMed, Medline, Science Direct, African Journals Online, and the grey literature as Google Scholar. It would have been good if they added the dates for their searches for reproducibility purposes. Then they also mentioned that they analyzed with the R version 3.61. And however, they did not mention the inclusion criteria. Risk of bias was not mentioned here, but the tool is mentioned elsewhere as the GBI checklist. In the results section, they do not list, although it's mentioned elsewhere, the number of studies. They also mentioned the prevalence of TB, traumatic brain injury, to be 20%. Mentioned the confidence interval, prominence of RTEs as 21, and assault as 18%. Of them having 95% confidence interval. So on RTA, you notice it was an editorial error where instead of putting it as confidence interval, they put it as IC. Then in the conclusion, they mentioned the need for urgent regulatory laws in transportation, pre-hospital emergency care systems in Ethiopia. And their keywords were relevant as head injury, road traffic accident, assault, and Ethiopia. I don't know, I think they should have added that terms like systematic review and meta-analysis, but I'm not sure. Thank you.
Hello. Yes. Thank you. Thank you so much. That is a very comprehensive feedback, and I agree with you. The review, the abstract is very well written. It's very short and it's easy to skim through, as Aditi has told us and as Teddy has told us. However, there are some things that were not mentioned, but they have been mentioned elsewhere, as you have said, like the risk of bias test, inclusion exclusion criteria, and Dr. Teddy was very precise. He was able to catch that there was an editorial error there. Very good. Does anyone else want to comment on the abstract before we continue? You can also use the chat, but you can change the option to send the message to everyone so that we can all see what you have to say. Okay, we can proceed. I believe Dr. Teddy and Aditi have covered all of the areas. So next we can proceed to introduction. I hand it over to you.
Okay. So in the introduction, Teddy again. So in the introduction section, they say the rationale is because TBI is a burden both globally and in sub-Saharan Africa, and they also showed that there are high numbers in Ethiopia, and they also showed that there is a knowledge gap that will help with the policy needs, because there's also absence of national Ethiopian prevalence data. So their objective is to assess the national prevalence and of TBI among trauma patients in Ethiopia. They highlighted also the regional relevance, as they had mentioned the Tikur, Anbesa, and Aider hospitals showing high prevalence in towns in the region.
Hello, yes, Teddy. Thank you for your contribution. I am also in agreement. I believe that they have shown the clinical and scientific basis for the review well, starting with the burden of traumatic brain injury globally in the United States, and then they've brought it back home to Ethiopia, and they've provided their data well, and their objective, which is to assess the national prevalence of TBI among trauma patients in Ethiopia, is very clear. So before we move, Anyone else want to add something before we move? Yes, I can see Aditi in the chat says that the definition, the clinical rationale has clearly been mentioned. The knowledge gap is also well summarized, and the existing evidence in global, regional, and local stepwise manner has been given. The review question has also been provided according to the PICO, and PICO format hasn't been mentioned. I don't know if Aditi, you can shed some light on that last part, but I do agree with you. Aditi, and if anybody else wants to contribute, I'm still monitoring the chat. Okay, we can proceed. Looking at the document we shared before the document we were supposed to read, I believe that the introduction has met the appraisal points. We can see the focused, relevant, and justified question and the aims of the study that are linked to the gaps in evidence. Fantastic. Let's continue. We can move on to the methodology. Here is where I believe we spend a bulk of our time. We can start with the protocol and the registration. Anyone with a comment?
In Dr. Teddy again, in methodology, so as earlier mentioned, they mentioned the Prospero registration code. And also here now they included the inclusion criteria as mainly cross-sectional studies, and they excluded the random control trials, cohorts, and case reports. The information sources, as mentioned earlier, were PubMed, Science Direct, African Journals Online, and Grey Literature's Google Scholar. Once again, they need to add the dates. Then also, it would have been good to mention they were if they were able to access the ministry reports, because I don't know if there's circumstances like Kenya where it's difficult to access those reports. Then their study selection, they did the plasma flow diagram, which was well done, which started as diagram 1, started with 198, then they toned them down to 21, then went down to the 12 that were included in the study, and also did dual independent screening, which was actually really nice, because it also helps in reducing the risk of bias. Then their data extraction, they used Excel, and the dual independent screening, and a third author arbitrator. And the variables they mentioned was the author, year, sample size, prevalence, mean age, and risk factors. And as earlier mentioned, their risk of bias, they used the GBI, critical appraisal checklist, giving their quality threshold as greater than 50%. For sensitivity and for the subgroups, they put them nicely in the figure 3 to 4, which gives out the analysis, and then they did a moderator analysis on the study quality, sample size, mean age, and publication years. They also mentioned for transparency that funding was done by the authors, and they did an ethical exemption of secondary data.
Okay, Dr. Teddy, thank you. Again, I am in agreement, especially on the point where we need to tell us the dates when we're looking at the articles, so that we can ensure that there is reproducibility. So on the chart, I see Aditi is saying that the protocol has been mentioned clearly. A lot of detail has been included. That's true. I see that the eligibility criteria has explicitly been mentioned in subheading, making it easier to analyze and read through. The grey literature has been vaguely mentioned. They didn't add which exact papers they went through. Was it a conference abstract or a thesis, etc.? So what do you think on that point as I continue? Screening process was also well described. For the diagrams, this is still Aditi's comment. For the diagrams, I think it's more of a website issue because the tables and link have been mentioned in different links and they open another tab, making it difficult to analyze texts within the diagrams, tables, plots, etc. I agree there. That's what's making it difficult to project here. But yes, risk of bias hasn't been mentioned anywhere along the text. Okay, for the data extraction, since they analyzed the mean age of people involved in accidents, it may have been beneficial to analyze it in terms of which category was affected or no such relation exists, as one can directly correlate it with the prevalence of traffic education in low and middle income countries, as they mentioned in their introduction. Yes, I believe I'm in agreement with Aditi's comments, but here, risk of bias, I believe they mentioned it, and Dr. Teddy has talked about it. Yes. Let me try and go back to the paper. Yes, thank you. Do we have anyone else who wants to comment before we proceed? Okay, I can see Clarence on the chat. He's saying that only specific search terms for PubMed were provided in the supplementary materials. It would have been helpful to include terms from other databases. I'm in agreement with that. What do you think? But yes, I agree. It's helpful. I believe it would be better if they told us like the terms for every database, not just one. That's right, Clarence. Anybody else I'm leaving out before we proceed? We have a chat from RISPA. I see that there are members of the meeting who have been able to send the message to everyone. Yes, I believe the chat has been fixed, so you can send your message to everyone. It's okay. So RISPA is saying that providing this specific string would have allowed for exact replication and a more granular assessment of the search's sensitivity and precision. RISPA, I don't know if you can elaborate.
The search string for whatever they actually keyed into the different databases to get the data, to get the articles.
The terms they keyed into the databases?
The paper says they used the Boolean and everything, but an addition of the particular search string that they keyed in would have been helpful to be able to replicate easily.
Oh, okay. I understand. I get you now. Yes, I agree. Yes, thank you. Thank you for the contribution. Anyone else? I'm logging out before we continue. So, when I look at the appraisal points for the methodology, there are 3 questions that we ask at the end of the review. So, was the search comprehensive and reproducible? Number 1. Were the inclusion, exclusion, and the quality appraisal transparent? Number 2. And were synthesis methods appropriate and clearly reported? Maybe before we continue to the results, we can have 1 or 2 comment on those 3 questions.
Yeah, hi. I'll start with the second question. They did that really well for inclusion and exclusion criteria. For the third question, although they didn't include some of the things in the methods, they included them in the results. They were also able to do, the third point was data synthesis, and the methods that they used, I think that was well done. For the first point, reproducibility was an issue because that search terms, like RISPA was saying, they were only provided for PubMed, and they didn't make it clear that the search terms used for PubMed were the ones that we used for every other database we used. So even if I were to try and reproduce it, I don't think I would come up with the same results because they didn't make that as crystal clear as they could. So if they could include that in the supplementary materials as well, that would have helped.
Okay, Clarence, thank you. Can we have one more comment on the 3 questions before we proceed? Maybe Dr. Teddy, you can tell us your thoughts.
I agree with what has been said, but on addition is just still once again on the dates, because inclusion and exclusion was well done, and synthesis was also seemed quite okay. But once again the reproducibility might be a bit difficult, but they were quite comprehensive because they mentioned each and everything quite well and without adding any fancy terminologies.
Okay, before we proceed, there's an interesting comment on the chat. I believe you can all read it. Eligibility criteria for the study, this is by Gibson. Eligibility criteria for study is elaborate. However, I have some reservation on the fact that they mention aspect of time was not taken into consideration. Fights being the second highest in the statistics given, I feel like it's recently that there was a rise in conflicts within the region, and it would bring a very different discussion around road traffic incidents if the fights were mentioned. What do we think? Okay, maybe in the interest of time, we can continue, but I can leave that question to you. So, from the methodology, I don't know why my screen is not okay. Yes, so from the methodology, we can proceed to the results. Thank you. We can proceed to the results. We can have our comments in the chat box, and you can unmute if you wish to talk. Just as a reminder, our appraisal points here, when we got to the discussion, we were focusing on the included studies now. Are their quality clearly presented? Are qualitative and quantitative findings appropriately summarized? And are the figures or tables provided complete and labeled? Those are our 3 questions. So we can have some few comments and then we proceed.
So for the results section, I think it was generally well written. They started off with a Prisma flow diagram. Okay, I downloaded it, and in the downloaded section, they started off with that, but it was present. And a summary of the characteristics of the studies was included, I think, in table 1. The authors also reported the number of studies and participants for each and stated the summary effects with confidence intervals pretty well. Forest plots were included, I think, from figure 2 to 4. All of them are forest plots. Although they were not as clear, they could have increased the clarity of them, but they were still included and well done. But heterogeneity, it was mentioned, and it was a cause for them to do subgroup analysis, but they didn't mention like where the differences were, like what was the cause of the heterogeneity, which would have been good to mention in the results and also in the methodology. But generally it was well done. That's what I saw.
Yes, thank you, Clarence. Can we have a comment on the implications? Yes. Oh, okay. Okay, good. So I think Clarence has summarized that well. So we can have a moment or two. I look at the chat, and if you feel you can unmute, kindly unmute. So in the chat, we start with Wambui, who says that in the first paragraph, it says that there were 14,017 participants. But in the meta-analysis section, it states that there were 12,915 participants.
Yeah, I think that's I also don't understand what's happening there. It's a huge oversight. Yeah. Yes, because also it's a huge oversight when you're comparing the description section and the meta-analysis section. Some things do not match. Because another example is they give a range, of sample sizes from 171 to 4,153. And I can see in the Oromia state mentioning a number greater than the range at 4,972 participants. Yeah, so there's some mismatches in the figures in the meta-analysis section and the results and the description section.
Okay. Have very keen eyes catching discrepancies in the figures. That's very good. Yes, I agree. And that's also a challenge I found when I was trying to conduct my own review. Maybe I can leave the floor open on that for anyone who has any comments while I read out what's in the chat. We have a comment from Lomi who says, the rise of conflicts within the region definitely brings about the idea of confounders and confounding bias. Gibson's take is quite interesting. Time and dates definitely should have been provided. And I agree with that. So we can maybe have a minute or two before we proceed to anyone else who wants to speak. Clarence, I believe you can unmute. You can unmute and talk us through this point.
Yes, so in the results section, it says the looked at 198 studies, but that seemingly came from nowhere because in the flow diagram, there's no 198 mentioned because it says it goes from 532, they remove the duplicates, it becomes 250, and then they continue from there. Like that figure just seems to come out of nowhere, unless I overlooked something. Yeah, so you can see 250 goes down to 145, excludes 124 all the way. So I don't know, did they just look at 198? Did they look at 250? That might have been an editorial issue, or maybe I missed something. Yeah, that was my point.
Yes, Dr. Teddy, did you catch that?
I hadn't checked on that, but yes, there's a mismatch there also.
Yes, and I see that's also the point that Aditi is raising in the comments. In the results section, they mention 198 papers, but on the Prisma flowchart, the numbers don't add up. Yeah, tend to agree with you. But we can proceed because I think we've tackled the three questions that we will ask in the appraisal points. But I believe we are seeing the importance of the review and the importance of reproducibility, especially with systematic reviews and meta-analysis. Yes, very good. I hope I'm not closing anyone out. You can feel free to comment. Even if we proceed, I will still read your comments. So we will move on to the discussion portion where again, we have three review points. So I think we start our discussion from there and then we proceed. So the appraisal points are, is interpretation balanced and evidence-based? That is the first question. Are the limitations explicitly acknowledged? That's point number 2. Are regional implications clear and realistic? Yes, we can start our discussion from there. Yes, as I'm monitoring the chat, we can begin with your responses.
So, Teddy again. So they mentioned higher prevalences in Ethiopia set up than global data, and they accredit it to road safety policies. The limitations were the regional gaps. They also had the heterogeneity and the low evidence quality. Then so they recommended a need for policy reforms, as earlier mentioned, in transport and pre-hospital emergency policies. Yes.
Yes, good. Thank you, Dr. Teddy. I don't know if you can tailor your response to the three questions and we attempt to answer them as we proceed. And not just Dr. Teddy, but everybody else. Feel free to comment in the chat.
Okay, so in the appraisal questions, the interpretation, okay, now we'd say it's evidence-based, but the issue is the results have mismatching figures. So I am unable to answer that one. The limitations were acknowledged with the knowledge gaps in the region, and the implications were clearly stated, where they mentioned the need for policy change, both on transport and pre-hospital emergencies. But I can't comment on the first one due to mismatched figures in the results section.
Okay, thank you, Dr. Teddy. What do we think about the policy changes that have been suggested by the paper as we conclude? Maybe there are a few of you in the chat. We have Aditi. Maybe you can tell us something before we proceed. Or even Clarence, if you're still here. Yes, Clarence.
Yeah, sorry, repeat the question, please.
Yes, I was asking about the policy changes or the policy reviews that have been suggested by the paper. What do you think?
Oh, okay, yeah. So that's in the conclusion, and they included recommendations for road traffic accidents, and I thought those were pretty reasonable, but they didn't include any recommendations for the assault, especially with all the tribalism. According to the people, there's tribalism and tribal conflicts going on. Maybe they could have suggested something. I don't know if that would have been feasible though to suggest, but I feel like that's something they should have suggested as well. If that makes any sense.
Okay, thank you. Thank you for your response. So, as we conclude, let's go to the conclusion and the references. So for our conclusion, we have it here. It's very brief. Our appraisal points are: number one, are conclusions supported by the data? Number two, are recommendations relevant and practical? I believe we've talked about the recommendations. We can talk about the conclusions. Are they supported by the data that has been provided? Okay, maybe because of time, I can give my thoughts. I believe that the conclusion is supported by data, especially here on the point where they mention the prevalence of TBI in Ethiopia and the role that policymakers have to create awareness strategies on road safety, regulatory laws on transport, mode of transport, types of vehicles, driving license, and pre-hospital emergency medical care that is highly in demand. These recommendations are made because we have seen that from the data, the prevalence of TBI among patients in Ethiopia is high when it is compared with continental and global reports. In the chat, I see Clarence is talking about the conclusion. It does provide a concise and evidence-driven summary of the paper, as well as avoiding over-interpretation. Yes. So finally, we can have one of us comment on the references. I see we are almost there. We're almost out of time, so we can comment on the references, the format, and before we proceed to hand over the mic.
Say the reference section was generally pretty good. Only 7 of the references were older than 10 years. But in the reference section, it also follows the Vancouver format, and all of the references also exist. I went through each of them, and they exist. And the authors also did a good job of referencing the methodological standards that they used. So they referenced the JBI checklist and the Prisma flow diagram format. So I thought that was pretty good. So the references are generally well done.
Yes, thank you, Clarence. I am in agreement on that. I'm seeing we don't have any comment on the chat. Maybe a minute. Anyone else who has a comment or maybe something that I've not seen in the chat? Okay, so Ian is mentioning references are adequate and relevant to the subject matter, though I find it difficult to see where reference 4 fits in the picture. Let me see which reference 4 is about. Okay, reference 4 is talking about deep vein thrombosis, endovascular management in medicine. Okay. On its citation, they talk about how, besides the impact on the individual, TBI can negatively affect families, communities, and the economy through loss of productive age groups and treatment costs. I don't know, Clarence, since you went through the references, what do you make of the comment?
Yeah, I'm also, because I usually just go through them and make sure they exist, make sure they've been referenced. Maybe they just took that from the actual, from the, like the words of the, what am I even saying? They probably just took that from the article, that statement, and not anything about deep venous thrombosis. Because the article itself is not open to public view. I can only read the abstract.
Okay, thank you. I had not even noticed that myself. Thank you guys for your participation. Again, it has been a very interactive session. You guys are very keen, and I encourage you to continue with being keen, even as you go out and review your own systematic reviews and meta-analyses. So at this juncture, I would like to invite Dr. Mercy Mitei to share with us her thoughts. And yes, Dr. Mercy, the floor is yours.
Thank you, Lee. Good evening, everyone. I'm happy to join you today, and I thank you all for the robust discussion that you've had. I had a list of 7 things to go through, but I'm happy to report that you guys have mentioned most of them. And I commend Ian for even noticing that one of the references seemed out of place, and RISPA for passionately talking about the full search strategy and how that should enhance, they should be transparent with that. So in the interest of time, I'm just going to, out of my 7 things, I'll just pick one that I feel like I should really highlight to this group that will help us when we are thinking and reviewing systematic reviews in the future. So maybe Lee, you can help me scroll to the results section where the forest plots. So fundamentally, what a systematic review is you're pulling together many studies and you're trying to compare them and come up with a pooled estimate or an overall estimate of whatever thing you're trying to study. And in this paper specifically, they were looking at traumatic brain injury, which is a clinically relevant topic. Are you able to pull up the forest plot? Or I can share my screen and show from my end.
Yes, I can share. Which one?
Just the 3 of them, the ones that Akini went through at the beginning. Yes, let's start with this one. So as I was saying, a systematic review and a meta-analysis, there's some fundamental things that have to be met, or a criteria that has to be met before you start combining the studies and start having a pooled estimate. And I'm happy that most of you have talked about the heterogeneity of the studies. If you look at this figure, they give you an I-squared of 99%. Briefly, what do you guys think about that? The figure 99, I-squared of 99%. Is it acceptable? Is it not acceptable? Anyone can answer.
This one I'm a bit not sure. Maybe I can give it to my colleagues.
Yeah, anyone else who wants, or maybe Akinyi, because she was doing the review.
I'd say that's like extremely high heterogeneity within that study.
Yes, thank you, Felix. This is very high, unacceptably high. So what this means is that the authors were basically trying to compare studies that are very different from each other. Essentially, in layman terms, we would say that they were trying to compare apples with oranges, which is not the correct way to go about systematic reviews and meta-analysis. You want to compare apples to apples and oranges to oranges, not apples to oranges. So that's quite a huge weakness in this paper, that the eventual 12 papers that they ended up with was so variable from each other to the point that the heterogeneity was 99%, meaning the population they were looking at, the outcome they were looking at, maybe the gender, the geographical distribution, all these things were different. So this is one key weakness of this paper, and how they handled it is doing a subgroup analysis, which means that they try to now group the papers into other smaller groups. Like, for example, maybe you can go to the next forest plot. They tried to analyze them in groups depending on the regions, and this is the second one. And then they also tried to analyze it depending on the mechanism of injury. But even with these the subgroup analysis, the heterogeneity was still quite high, meaning even the studies that they were lumping together as similar were not as similar as we would want them to be. So in statistics, there are two ways of dealing with the effect each study carries. For example, as Akinyi correctly put, the squares, the small squares, are the effects that each study contributes to the overall pooled estimate. So it is assumed that at the beginning, before you start your analysis, the assumption from the authors would be that each study would carry an equal effect to the overall pooled estimate. But if your studies are very different, then one way of dealing with it is called a random effects model, which is what they've given us down here. If you see it on this forest plot, they've written a number and they've put a random effects model next to it. This means that the authors assigned different weights to the studies. They did not assume that each study carries an equal weight at the beginning. So they allowed the studies to either have a higher or a lesser weight than the others, depending on what they thought, like how close it was to their primary outcome. An example is if you scroll down in this region they're calling Tigray, the last one, the very last one. It's only one study in that group, like only one study in that group. And then you can see the proportion is 0.49%, 0.49, but it's only one study in that group. So you cannot really interpret that and say that this is statistically relevant if only one study is in the group. And that's why when they come to the random effects model and the weight they gave to it, it was I think they didn't even indicate what weight they gave to it. But I hope I'm communicating something. Like, this was the greatest weakness I saw in this paper, that they really tried to put things together that they were not going together. An I-squared of 99% is truly high. It's almost unacceptably high. So in research literature, you'll see an I-squared of 50% is unacceptable, but anything above that, you need to have a robust way of dealing with it, either doing further subgroup analysis and within the subgroup having like less variability. So I would say the results here, we would interpret them with a pinch of salt, just because of that heterogeneity. And even within the subgroups themselves, there's no sensitivity analysis to see if to like account for the heterogeneity within the subgroups themselves. I think this is something that we can discuss further if you're interested, but I hope I've communicated something. It can be a bit confusing at first to pick that up, but I'm happy that a couple of you actually were talking about it. I'll leave my comments there. Let me see if there are any questions. And then, I'll hand it over to Lee. But I would say everything else that I meant to say, you guys have picked it up beautifully. From the search strategy to the absence of dates, which is very important because it affects the how we can reproduce the methodology. And also, it kind of removes the credibility of the systematic review because we don't know how recent or how how outdated the papers that they included are. Although if you look keenly at the papers, they're from 2011 to 2019, but it shouldn't be the readers' work to tease out the date or the timeline in the systematic review articles that were included. Thank you. Let me hear if there are any questions.
Wow, thank you, Dr. Mercy, for your input. Wow, that is something I will even have to read further myself. So, in the interest of time, if you have a question for Dr. Mercy, please feel free to mention it in the chat. But right now, I want to invite Felix to tell us a few words before we end the meeting. Thank you.
Thank you so much, Lee, and thank you, Stacy, for the initial summary of the paper, and to our guest editor, Dr. Mercy, thank you so much for joining. And on behalf of EAJNS, I am grateful for all of you who've participated, contributed, submitted your reports, and made this session lively as well. So this was session 10. Of the Critical Appraisal Bootcamp, and it's been yet another session where we share our ideas, learn from each other, which I believe is really, really important, and also get a hands-on experience just to see what a good study should look like and what it should not look like, even as we grow as early career. Most of us, we are all early career researchers, maybe some mid-career, but we're all learning and it's a journey. So kudos to all of you who've made it this far into the bootcamp. As I shared in the email leading up to this session, this was going to be the last session where we do this formal appraisals. So basically, this was the last session with homework, and we have 3 more sessions, but then those ones will be more reflective, and you'll not need to do a lot of work or any work per se prior to the session. It's just for us to come and have some interesting discussions as we wrap up and consolidate all that we've learned through this bootcamp so far. And so we'll send the details of the next session over the next few days. So thank you so much. Maybe Lee, you can take over and just read out the question on the chat box. Thank you.
Thank you, Felix. So there's a question, I believe this is for Dr. Mercy. In a situation where there isn't much data, as in this paper, how do you handle the high heterogeneity that would probably arise?
Thank you for that question. Just kindly elaborate on what you mean by no data. Yes, Lynn, go ahead.
What I meant was, so in this, they admitted that there wasn't much data, many papers, like in the Tigray area, for example. And so it would have, I'm not justifying what they did, but it would have been like impossible for them to get another paper that could have been similar to the one that they had put in that subgroup. So if you're in a situation where you don't have many papers, then what do you do? Yeah.
Okay, thank you for your question. I understand it now. So in that scenario, then you will not be able to do the meta-analysis portion of the systematic review and meta-analysis, because the systematic review is just pulling together the papers, but the meta-analysis is actually putting the papers together and trying to analyze and come up with a uniform result or an uniform estimate. And it's not also a must that you do the subgroup analysis. So the reason why they ended up with only one paper for that region is they analyzed it based on region. But I guess there are other ways you can group these papers. For example, the easy things would be to group them based on the ages of the patients, based on the gender of the patient, and to their credit, also based on the mechanism of injury, which they did. But if they saw that if they based it on region, they'll have a group that only has one, then probably that would not be a prudent way to group the papers they already have. They would have picked another way to group the papers, and the easiest ones are usually age and gender. That's why you see them on most meta-analysis, age and gender. One additional comment, I loved the discussion by, I think it was by Rispa and Clarence, about the full search strategy. And I would say from the editorial perspective, we expect that they give us only one of such full string. They don't need to give us for all the databases they've searched, but they need to include one in the supplementary material given. So different journals will have different guidelines, but for most journals, they will only require one out of all the ones that they have done. Only one is required for publication.
Okay. Thank you, Dr. Mercy, for shedding light on those areas. Mine is just to conclude, to thank you all for joining and for taking part in this bootcamp. Thank you for your comments and making this discussion as lively as it was. See you in the next session. Thank you.